This is head, neck, and face injuries. We're going to whip through two different PowerPoints here. One is the Portage PowerPoint. The second one is the one attached to your textbook. So, PowerPoints. Topics, we're going to look at facial injuries, throat and soft tissue injuries, neck injuries, and eye injuries, and how to deal with all of these. Straight flip through that a little bit too quick. Here's some examples of facial injuries. We talked the other day about raccoon eyes. This guy definitely has raccoon eyes, the two periorbital ecchymosis, or accumulation of blood underneath the eyes here. Periorbital meaning two, peri meaning two, orbital eyes, ecchymosis is bruising. This guy is definitely, because of the blows to the head, potentially suffered a skull fracture. So, bones of the face, we're not going to spend a huge amount of time on here. We have the cranial bones up on top, zygomatic, or the cheekbones, the maxilla, the upper jawbone here, the mandible, the lower jaw. Those are the main ones you need to worry about. The nasal bone up here. This is the one that sometimes people say they break their nose. More often than not, it's the cartilage in front of the nasal bone. Okay, facial injury concerns any mechanism of injury that produces a facial injury should be considered a cause for spinal injury. So as you're approaching your patient, when you're doing C-spine consideration, anyone that looks like they've had a shot to the face, you should worry about C-spine. Ask them not to move, take C-spine, or delegate C-spine to a firefighter. Airway compromise is of paramount concern as well. Facial bleeds often bleed profusely, and if there's any laceration inside the mouth, penetration from the outside to the inside of the mouth, airway, etc., bleeding into the airway is a concern, so watch that. These are called periorbital ecchymosis. Again, this is raccoon eyes. You can see where it gets its name. And this is battle signs, the bruising behind the ears. Okay, these are both the same man. He has both raccoon eyes and battle signs. Basal skull fracture, very bad. C-spine support there, transport immediately. Here's another example of battle signs, a little more subtle. Okay, more raccoon eyes, more on one side than the other, but you can see that it's not just your typical black guy from getting smacked in the face with a basketball. The coloration extends to the upper lid as well. Okay, factors of airway obstruction. Somebody gets shot in the face, or a shot in the face, a smack in the face, any kind of trauma in the face. Profuse bleeding with clots takes place. Loosened teeth or dentures. Okay, and those loose teeth can impair the airway if the patient is unconscious or laying on their back. Injuries to the airway that cause a deformity to the structure of the airway. Okay, if you get a patient that has a blow to the trachea, the hyoid bone, which is just to the anterior of the trachea, as well as the cricoid cartilage, those can be crushed, causing a deformity and an eventual swelling of the airway, which can cut that off. Which is the next topic there, or the next item, swelling of the soft tissue, and direct injury to the trachea or larynx. Okay, loose teeth. This is all a bad one here. Somebody catches something in the chiclets, knocks a tooth down, or knocks a tooth off. I would imagine, Neil, you probably got a couple of loose teeth or something along the way. Somebody like you couldn't go through life without losing a tooth or two. But anyways, signs and symptoms of a facial fracture. Okay, if there's a deformity to the face, inability to move the jaw, irregular bite, loose bone fragments, swelling, bleeding and bruises, absent or loose teeth, inability to swallow, inability to talk, increased salivation because it's difficult to swallow, blood in the mouth, abnormal eye gaze, profuse bleeding from the scalp or face. You also may have paradoxical motion of the jaw. I remember dealing with one 8-year-old kid that got kicked in the face by a pony chariot horse when he walked behind it. And as he was talking, it looked like a marionette because part of his jaw was moving up, the other part of his jaw was moving down. His teeth were split exactly where his bone was, his jawbone, lower jawbone was broken, and his mother actually fainted. We caught her before she hit the ground when he was talking to her. It was kind of a freaky time there. Anyways, management of facial injuries. Always deal with your ABCs, of course. Airway, breathing, circulation of paramount concern. Whoops. Control the bleeding with direct pressure if possible. Remember, do not put pressure directly on the airway or anywhere around the neck. Okay. Be careful with soft spots on the skull. If you have any deformities or softening of the depressions in the skull, be really careful with putting direct pressure there on a head laceration. Cold pack to reduce the swelling if possible. Inspect the inside of the mouth if possible, and suction as needed. So if this person is lying down unconscious, you need to be careful to suction that blood out of their airway. Always consider C-spine. You should have them in C-spine already before you start doing any of this stuff. Before you even start your ABCs, you should have them in C-spine, and nothing by mouth. Don't give them anything to drink, eat, anything like that. An impaled object in the cheek. Okay, and be very careful. Removal of the object can be done by the caregiver. Care should be aimed at minimizing further injury and airway maintenance, and suction and bleeding control to the inside of the mouth is a key. Okay. I've often been told that unless it is interfering with your airway maintenance, then leave it in place and let the doctor take it out. If, say, somebody got something shoved through their cheek, or stupid things, a toothbrush shoved in the back of a patient's throat. Some kid was running down the hall, tripped, fell, shoved his toothbrush and lodged it in the back of his throat. If you removed that toothbrush, there is the potential for increasing the amount of bleeding directly into the throat, where you can't put any pressure on it and you can't suction the blood out, go straight into the airway. So be very careful in removing any impaled object, only in circumstances where you cannot guarantee that that patient's airway is secure. How do you care for this guy? Boy, he's got a facial bruising, swelling. You can barely tell his nose is there. Okay? Epistaxis, nosebleed. Okay? Believe it or not, we do get called for bad nosebleeds. Large clots can move to the back of the throat, can occlude the airway if they get inhaled. It's not a good thing. So, previous injuries to the nose with some deformities. Dry air cracks the membranes. That happens this time of year with my own kids. There's trauma. Picket, it bleeds. Yeah, this is what happens in kindergarten, grade 1 and 2, and junior high sometimes. Hypertension. If you've got a high blood pressure, you may have more of a tendency to nosebleed. And vascular diseases weaken the wall of the blood vessels, making them bleed. Epistaxis care, apply gauze below and wrap around the sides of the nose. Squeeze on both sides. Have the patient tilt head slightly forward so that the blood doesn't drain into their airway. Cold pack to the back of the neck. Hey, I said that last week, didn't I? And, last but not least, we're clicking here, gauze under the upper lip method just to place pressure on it. You can also try to put cold pack over top of the nose to try to cool it off, or try to slow it down as well. Okay. You can see there, actually, with this one, they're putting a piece of gauze under the lip to try to block the flow of blood with the upper lip. I've never tried that, but okay, injuries to the throat and neck. Primary concern is adequate upper airway. So in other words, if someone gets a shot in the neck, a trauma to the neck, basketball or volleyball or a golf club or a baseball bat or something to the neck, is potential there for upper airway swelling, as well as damaging the hyoid bone and the trachea, as I was saying before. Consider injuries to the soft tissue injuries of the neck to be injuries of the C-spine as well. So if you see someone has bruising or bleeding or anything of that nature to the throat, like this, okay, always secure the C-spine, because if the mechanism of injury is sufficient to cause that kind of damage to the front of the patient's throat, it is possible that it could have damaged the cervical spine as well. So signs and symptoms of laryngeal or tracheal injuries: obvious trauma to the area, like this one here. That's right over top of the Adam's apple, or the cricoid cartilage there. And the cricoid cartilage is part of the larynx. Pharynx up above, larynx right here, voice box. Loss or change in voice. Of course, that's where your vocal cords are, is right in that area as well, the larynx. Signs of airway obstruction. Of course, if the larynx takes a hit, there is a potential for swelling of the soft tissues, or the deformation of the cartilage that makes up the larynx, and it could impair the airway. And subcutaneous emphysema is potential if it was a bad blow. That subcutaneous emphysema, of course, you guys should know what that is. That's the bubble wrap feel of air underneath the skin of the chest. So managing a tracheal or laryngeal injury, again, airway, breathing, circulation, we come back to this. Suction is needed cautiously. And again, with suctioning, if you remember airway maintenance when we did the respiratory system, we do not suction any deeper than we can see, so essentially to the base of the tongue. Oxygen, of course, if we have someone that has a laryngeal or a tracheal injury, it's also a breathing situation, and we want to make sure and maximize their oxygenation. Assisted ventilations is needed if we need to put an OPA in there, if they lose consciousness, if they do not have a gag reflex, spin an OPA into them, bag them if you have to. Spinal mobilization, of course, okay, occlusive dressing to large vessel injuries. So if we have someone who's taken a skate across the throat, for example, we want to make sure and put an occlusive dressing to large vessels. This is not only for blood loss, but it's also for air embolisms. It is possible on large vessels to suck air in. Now, we would probably never arrive with an ambulance to someone who had a lacerated large vessel in the throat, but if you're ever on scene at a hockey game or just playing with friends, someone takes a skate to the neck or to the throat, cover that thing up with a gloved hand or whatever you've got as soon as possible, because there is a chance of introducing an air bubble into the blood vessel, besides losing all that blood, and that air bubble will do some damage as well. Never, ever, ever place a dressing directly around the neck, because the blood flow will be impaired and you'll cause more problems than you're creating, or than you're fixing. Some more information on eye injuries. This person's gaze is obviously impaired. This eye has got some damage to it. We've got some bruising, and you've got the uncoordinated eye movement. Okay, so the eye structures, it's made up, it's basically a hollow ball that is filled with what's called vitreous humor in the posterior cavity, or the main body of the eyeball, and it has aqueous humor in the anterior, which is up in front here. You have the pupil, which is the opening part. Okay, we have the cornea which covers the pupil, or covers, it's basically the window into the eye. And that cornea is what often gets scratched or gets burned in welding flashes, or gets dried out, and so on. It's what gets damaged the most when we deal with eye injuries. You get something stuck in the eye, a piece of metal or piece of dust. It's the cornea, or this outer part covering the eye, that ends up getting damaged. Now, of course, we've got the rods and cones line the back of the eye here, called the retina. Okay, and then we have sets of muscles that surround the eyeball that allow it to move. We're not going to spend a whole lot of time on the structures of the eye. We just need to understand some of the major ones. Then most of the time, eye abnormalities are going to be limited to swollen eyelid from inflammation or from irritation, a lacerated eyelid, something gets cut. Okay, eyelid gets cut. Bright red conjunctiva, that can mean there's irritation, broken blood vessels, or infection within the eye. Excessive tearing, exposure to toxins or irritants can cause excessive tearing. Bruises around the orbit from a blow to the eye, or accumulation of blood in the orbital area from a basal skull fracture. Change in appearance or function of the eye, or it moves differently because of a blow to it. Objects embedded in the eye. This is probably by far the most common injury to the eye that you're going to end up with. We try to minimize that by prevention and use of safety eyewear in the workplace to prevent objects from industrial areas getting stuck in the eye. Burns, this is thermal burns as well as radiation burns. Thermal burns, in a fire, most of the time the burns are going to be of a radiant nature. Looking at the sun will cause a burn to the retina as well as the cornea. Welding flashes, if anybody's ever heard of that before, it's where you actually, the UV produced by the welder's arc actually sunburns the surface of the eye. It's like, and you wake up the next day, it feels like somebody threw a handful of gravel in your eye. There's also deformity, deformation of the eyeball itself. Causes of eye burns, there's going to be chemical burns, thermal burns, and light. This is what I was just talking about with a welder's flash or the sun. Chemical burns, fairly self-explanatory. Chemical gets splashed into the eye, fumes get into the eye, and so on, and cause an irritation. Very important to flush thoroughly for at least 20 minutes as per instructions on the bottle and from the poison control people. Thermal burns, this is temperature. Again, you want to cool the burn as best you can, and cover the eye with sterile dressing to prevent any infection. And with light, we'll look at that. When your light burns to the eyes, this is from infrared rays, from heat. Eclipse light, oftentimes people with a solar eclipse, the moon covers the sun. People think they can look at it because the light is decreased. The light has decreased, but the amount of UVA and UVB and gamma radiation and everything else is still the same coming from the coronal mass, and it'll still damage the retina at the back of the eye as well as burn the cornea. Bright snow will lead to snow blindness. That's a whole bunch of reflected light coming up from the snow, and it'll cause it's almost the same thing as a welder's flash. It's like a sunburning of the eye. Laser light, this is why people down in the States and in Canada are being arrested and thrown in jail for shining lights, laser lights at airplanes and at vehicles and stuff. Because some of these high wattage lasers can actually blind someone, and even the little small ones you've got, like for the pointers, they can do damage to the eyes as well. So shining a laser at anybody is just looking for trouble. Welding burn, and that's what I was just saying, the flash. The welder's arc actually makes a light that's very comparable to the light coming from the sun, and it contains the full spectrum of radiant energy, including UVA, UVB, gamma, and so on. Not so much gamma, but you get the idea, and you actually sunburn the surface of the eye. So signs and symptoms of burns to the eye, unless it's a direct thermal burn where you're involved in a fire or something, a lack of pain initially. A lot of times you're not going to see you're not going to feel a lack of pain. You might get a bit of a white blotch. You know what it's like when you get a bright light shone in your eye and you get kind of that white haze or a blind spot in your eye where the cones and rods have been overstimulated. Well, gradually it'll develop into more severe eye pain, tearing and swelling, and like I said, a handful of gravel in the eyes. It's just not even nice. Pardon me. There's some examples of blunt eye trauma. If you take a blunt trauma, that can be a baseball, it can be a football, an elbow, a hockey stick, a puck, anything like that, a blunt trauma to the eye can cause damage to the muscles that control the iris. It can damage the muscles that control the eye itself. It can actually rupture the eye. It can cause deformation of the eye. So there's numerous things that can take place. Pain, double vision. The double vision is because the eyes are no longer moving in coordination. Not a good thing. I keep talking about that friend of mine that had the issue with the blood, or not the blood. He ruptured a blood vessel in the back of his brain, and his vision was sideways for a while. He had double vision for a period of time too, until his eyes got better and his brain got better and so on. His vision is pretty much normal now, but abnormal eye movements. There can be twitching or uncoordinated movements and so on. You may experience flashing lights or what are called floaters, and I get these. I'm sure lots of people get them, but floaters are kind of characteristic of a blunt force trauma to the eye or a head injury as well. Basically, what these are, as far as I know, and the way I understand it, is that they're small pieces of tissue that have broken free from the retina. Now, a detached retina is a very distinct possibility in blunt eye trauma or head trauma, and detached retina means that the area that we use for converting light energy into a signal for our brain to interpret detaches from the back of the eyeball, basically peels away. The detachment can be fixed in some circumstances, but it's very, very severe, and you can potentially lose the entire vision in that eye. So an obvious eye trauma, if you can see it is distorted in terms of shape and so on, or ruptured, it's fairly obvious, and pupil can be distorted as well. So foreign body management, you get a foreign body, something foreign in the eye, dust, dirt, something stuck in the eye from a welder or a grinder. You want to gently irrigate the eyes with saline, okay, and this is like 0.9% saline or eye wash solution. In the absence of that, plain water, okay, sterile water. Patient may feel the object is still in there due to the scratch on the cornea or the eyelid. A lot of times that irritation is going to stay like that for a period of time. You should have a doctor look at the eye, even if the object comes out. If there's damage to the surface, they may put you on prophylactic antibiotics and eye drops to help heal the eye, and they may patch it as well. Removal of under the lid object. Have the patient look down, so if the object is still stuck in there, like an eyelash or a piece of sand or anything like that, grasp the eyelash, put a cotton swab on the lid, pull gently forward, up and over the swab, and use a second moisten swab to remove the object. So, you know what? These are very good instructions, but there's also some really good images in the textbook that shows you how to go ahead and remove an object from underneath the eyelid. Impaled objects in the eye. So if you've got someone that has a stick or a knife or a pencil or any kind of an object like that, large, that's impaled in the eye, support the object with a sterile dry dressing. If you guys remember back to your first aid course, place a bulky dry sterile dressings on either side of the object if it's a stick or something. Immobilize the object with minimum movement to the object. Okay, you don't want to wiggle it around, you're going to do more damage. Never ever remove that object, leave it in place. Cover it with a paper drinking cup. Okay, you can use a Tim Hortons cup for that, a styrofoam cup. You use a triangular bandage that's folded into a cravat, and you can use that to hold the object the cup in place. You can even split or tear the cravat in the middle just a little bit so that it fits over top of the base of the cup, and it'll hold it in place. When I come back on Tuesday, remind me, and I'll show you guys how to do this. Cover the other eye as well. Okay, covering the other eye will make sure that it'll help prevent movement of the impaled eye. So if you think about it, if you close your one eye, your other eye still wants to move around, and they both move in a coordinated fashion. So you need to cover both eyes. Now, psychological distress, they have no sight anymore. You've just taken both of their eyes away from them. You need to stay with that patient, stay in complete contact with them, and remember, you're now dealing with a blind patient. They're going to be stressed out because of that, and you don't want to abandon them to walk into a wall or anything, otherwise they're going to be really choked at you. So burn care to the eye. Usually flush this with water or saline for 15 to 20 minutes. Dress both eyes. Again, same thing as the impaled object. You don't want the eyes to move around, so put a dressing on both eyes. So if you've got someone that has a displaced eyeball, one's popped out, okay, avoid replacing the eyeball in the socket. Yes, trophum, leave it there. Don't let it. Don't be tempted to pop it back in, because it's not a good thing. Okay, cover it with a sterile, moist dressing. Of course, we don't want to use a dry dressing because it will tend to stick. And if we allow the eyeball to dry out, it will actually be worse than if it's wet. Okay, it'll actually cause damage to the tissues. Stabilize it with a paper cup again, just like the impaled object, and cover the unaffected eye so that we don't have a temptation to move the affected eye as well. Blunt eye injury care, we want to make sure we take C-spine control, supine for transport, in other words, lying down, and cover the eyes to reduce movement. Contacts. The caregiver should not attempt to remove a contact unless there's a problem irrigating the eye, such as the chemical burn. If you have contact in and you have a chemical substance in the eye, the contact can actually be stuck to the eye by the chemical action, dissolved and then sticks to the eye. The contact can also hold chemical between the contact and the eye to cause the continual burning as well. So you want to make sure and try and remove the contact if possible when you're irrigating. Okay, styes. Essentially, these are pimples within the eyelid, little infected area there. It could be caused by an ingrown hair. It can be caused by something within the skin and so on. It can irritate the eye, and just seeking medical attention. We're not going to deal with these very often, and that's about it for this section. The next one I want to do really quick. It's only a few slides, and it's directly associated with the textbook. So I want to turn the bloody sound on this stupid thing. I hope it doesn't have sound on all of it. But anyways, we'll get on here. Now, in dealing with, we're just going to stop this, and we'll go this way. Okay, so general signs and symptoms of a head injury. Okay, altered LOC, of course, irregular breathing, open scalp wound, penetrating head wound, softness or depression of the skull. This is what you're going to find when you do your hands-on, top to bottom real quick, okay, during your rapid survey. Blood or cerebrospinal fluid leaking from the ear, nose, or mouth, and facial bruising. Raccoon eyes, bruising behind the ears, called battle signs. Abnormal pulses, movement sensation, severe and disabling headache or one of sudden onset. Nausea and vomiting, unequal pupils, and again, like I said, the eyes are the window into the brain. If you've got unequal pupils or one is starting to get more sluggish moving than the others when you do your pupillary check, that's a big notification there's something going on inside. And of course, seizures. These are all head injuries. This isn't just a laceration or a cut on the cheek or something. These are severe head injuries. So general emergency care for head injuries, again, airway, breathing, circulation, and like I said before, is if you, what we should have up here is before one should be C-spine. Why isn't it in there? C-spine. Take C-spine if they had a head injury. Make airway a top priority, control bleeding, and dress open wounds. Apply rigid cervical immobilization device as part of C-spine control, and we'll talk about that later too. Monitor vital signs, and that should be Q 5 minutes, right? Every 5 minutes. Calm and reassure the patient, and keep a close eye on them. Signs and symptoms of a brain injury, which is associated with a head injury, okay? Changes in LOC, once again. Paralysis or flaccidity, okay, if they're very flaccid or limp. Unequal facial movements, squinting, drooping, unequal or unreactive pupils, vision disturbances. Now, I'm thinking about this in terms of trauma, but brain injuries can be traumatic or they can be medically induced. I'm thinking of a stroke, okay, or hypoglycemia, or epilepsy. Any of those can cause a brain injury or an interruption of brain function. Ringing in the ears or loss of hearing, rigidity in all of the limbs, or loss of balance. Slow, strong heartbeat that gradually becomes rapid and weak. Okay. signs of shock. High blood pressure with a slow pulse, that's usually an ominous sign. Okay, high blood pressure, slow pulse, and rapid labored breathing is called is what's called Cushing's triad, and we need to remember this one. Okay, Cushing's triad. And oh, come on, you'd think I'd never typed before. Cushing's triad is the high blood pressure, low pulse, and rapid labored breathing, or Kushmal breathing, and that that indicates an increased intracranial pressure. So the person is bleeding into the brain, or their brain is swelling. It may be because of inflammatory response, or a bleed, or a concussion, but because of the increased intracranial pressure, there is higher blood pressure, slower pulse, and rapid labored breathing. The treatment for Cushing's triad is hyperoxygenation, where we bag the patient at over 20 breaths a minute. We used to call it hyperventilation, but we don't hyperventilate, we hyperoxygenate. We bag the patient 20 plus. Okay, vomiting after a head injury or incontinence. If a patient loses control of their bowels or their bladder, it's definitely a head injury. Come on now. Signs and symptoms of a concussion. Somebody gets a shot to the head. Okay, momentary confusion, and even more confused than Katie is. Oh, no Katie in this class. That's block 2. 3, 4. Doesn't matter. Momentary confusion. Inability to recall events before and after the injury. So in other words, when you do your AAO times 4, person, place, time, and event, they may have a deficit there. Repeatedly asking what happened. I've dealt with patients that reset themselves after 2 minutes, and they didn't have any clue what happened. And you can explain it to them and everything, and they go, oh, okay. And then they go, what happened? And they wouldn't have any idea. Mild to moderate irritability, inability to answer questions or obey commands. Again, that when you're doing your person, place, time, and event with their LOC questions. Persistent vomiting, and a lot of times head injuries are going to give you projectile vomiting, where they're puking for distance. Incontinence, urinary or fecal incontinence, restlessness, seizures, brief loss of consciousness. Any loss of consciousness for a brief period of time or longer period of time is considered a concussion. Okay, for sure. Signs and symptoms of facial injuries. Well, I don't know if I have to explain this. Okay, distortion of facial features. If your nose is no longer pointing in the direction it should, there is a facial injury involved. Okay, numbness or pain, bruising or swelling, bleeding from the nose or mouth. Limited. Some of these are just ridiculous. Yeah. What else is there going to be if you're bleeding from the nose and mouth? Must be a facial injury. Oh, yeah. Limited jaw motion, missing teeth or teeth that don't meet together. Double vision or asymmetry of facial bones. So in other words, if you look at the person, the one cheek is higher than the other or something of those natures. Signs and symptoms of jaw injuries. Mouth won't open or close. Drooling of saliva mixed with blood. Difficulty speaking. Pain when speaking. Missing loosened or uneven teeth. Teeth that don't meet. Pain around the areas, around the ears, sorry. Of course, because that's where the jaw meets the temporal bone, the temporal mandibular joints. And also with this one, paradoxical motion of the jaw as well. With nose injuries, take special care to ensure that the airway is open and clear and the patient can still breathe. Position the patient to prevent blood from draining into the throat and apply cold packs to reduce swelling. Ear injuries, if you're dealing with Mike Tyson, you got to be careful and make sure he doesn't swallow it. When dressing an injured ear, place part of the dressing between it and the side of the head so it doesn't stick. Okay, and never probe the ear. Don't stick anything smaller than your elbow inside your ear. That's what Grandma always told me. Okay, signs and symptoms of neck injury. Again, obvious lacerations, deformities, obvious swelling, difficulty speaking, airway obstruction. You can hear them having difficulty breathing. It's a higher pitched upper airway sound. Crackling sensation of the skin, or you guys should know what that is, subcutaneous emphysema. Eye injuries. Carefully examine orbits, eyelids, mucous membranes, globes, pupils, and movement of the eyes. When you're going to care for that injured eye, flush only for chemical injury. If the eye is not perforated, making sure that it's doesn't have a hole in it, or it's not displaced or majorly injured. No salves or medicines. Do not remove any blood clots. Don't force the eye open unless you're flushing it. Sometimes people will clench their eyes closed if they have a chemical burn, and you might have to hold their eye open. Don't let the patient walk without help, because if you're going to patch both eyes, like it says here, you're taking away their vision. You want to walk with them. Don't allow them to eat or drink. Don't panic, and have the patient see a doctor. Last thing is extruded or impaled eyeballs. With extruded eyeball or impaled eyeball, you should cover both eyes. Don't apply direct pressure, like I said. The other one is to stabilize the object, put a cup over it, keep everything in place, transport them in a position of comfort, give them oxygen, and so on. Okay. Don't save. Okay. So, ladies and gentlemen, that is about all I have for you. I will, when I'm back tomorrow, we are going to be doing some scenarios. We'll go over the questions for injuries to the head, face, and neck. Mrs. Jingraw, Mrs. Cadieu, and Ms. Decker and Ms. McGregor have the question booklets for you guys. So I will shut up now. It's been 30 minutes and 28 seconds. Have a great day.